Hello, 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 everyone. It's Dr. Tamara Beckford with Your Caring Docs. But we are at the Dr. Tamara Beckford Show, and I am excited. Yes, I am very, very, very excited. Do you know why? Because we're at 150 interviews. Yes, and I have the lovely, lovely Dr. Chiaramonte, or you can call her Dr. Chiaramonte. Yes, she gave us the pronunciation. She gave us two ways to pronounce, or her patients love to call her, hey, Dr. C. Hey, what's going on, right? So we have the lovely, lovely Dr. C here. This is my friend, Dr. Delia. And we're going to be talking about integrative palliative medicine. I know that's going to pique your interest, right? But before we go all into that, I have to say again, I am excited because she's my 150. Yes, yes, I see the chat is lighting it up. Now, this is the Dr. Tamara Beckford Show, where I get the honor and the privilege of highlighting my friends who are doing amazing things inside and outside of medicine. And they are all highlighted on our website. So after this show, you'll be able to see Dr. Chiaramonte's beautiful face there. You just click on the audio and you'll be able to listen to this. So where can you find her? Just go to yourcaringdocs.com. That's URCARINGDOCS.com. Select podcast, look for her beautiful face, and boom, click that listen button. That's right. You'll be able to see her. Now, how did I get to this 150? Because of all of you out there, all my wonderful friends who are doing great things. So if you are a physician and doing wonderful things inside and outside of clinical medicine and would like to highlight it, send me an email at drbeckford@yourcaringdocs.com to book, and we will get you on. Do keep in mind, our show is booked out 3 months in advance because there are just so many wonderful people. Yes, and I want to highlight you. So if you have something beautiful that you have coming up, grand opening, book launch, anything, time it up, and then we will get you on the show. But for now, I have the honor of bringing on the wonderful doctor. So this doctor here is a graduate from Drexel University College of Medicine in Philadelphia, and she did her training at Thomas Jefferson University Hospital in Philadelphia, just like me. So we're twinsies. Yes, 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 yes. Now, this wonderful doctor is not only a graduate of Thomas Jefferson University, right there in Philly, off of 11th Street, right in Center City.
Yep. The best.
But she's also the CEO and founder of the Institute for Integrative Palliative Medicine. Right now, in this institute, she creates physician leaders who provide whole person care for people with serious illnesses using all the tools that work. Right? All the tools that work. So she's been doing this for many years, and she has culminated all of this experience to help you out there to be physician leaders, to help people with serious illnesses with all the tools that work. So Let me tell you, we cannot wait to welcome the one and only Dr. Delia Chiaramonte. Oh my goodness.
I'm so excited. Thank you so much for having me. I am so excited.
I am honored. Like, this is beyond exciting having you on. Alrighty. So, all of our docs that come on, we have different stories, and this is great because these stories are here to inspire everyone who's listening, inspire you to go and push, and there are more things that's in you. And even if you're a physician, you're not just a physician. You're a physician with other skills and talents that you can bring to this world and help to make a difference. Now, all of that started way back. And that's what I want to hear from you today. So what is it that made you, Dr. Delia, decide, you know what? I want to be a doctor. Take us back.
So I started a different path first. I was going to be a veterinarian.
Oh,
Since
I love
I
it.
was teeny tiny, I was obsessed with animals. I read the James Herriot books like 15 times each. Everybody who knew me knew that was my thing, was animals.
Right?
I worked in animal hospitals since I was 11, and I lived in
Wow.
LA at the time. And so
Mhm.
one of the hospitals I worked in was like, they had cardiologists and fertility specialists. We used to collect samples from the males and then do insemination. That was part of my job as the low level person.
Oh my goodness.
So, and I picked the vet school in Colorado that I wanted to go to. I went to the undergrad, even though it was really kind of not my scene. It was like an ag school. I came from LA, but I was so focused. I was going to be a vet. And then I got there, and it was kind of a small town at the time. And I worked in a vet's office, and the vets were coming out saying, don't do it, don't do it. Because a small town is different than LA, right? They're like, we're just doing spays and putting dogs to sleep. You should go to medical school instead. And so I had a total crisis, but luckily all the prereqs were exactly the same. So at the last second, I pivoted and applied to medical school, and then I went to medical school.
Wow, what an amazing backstory. Okay, so we're here growing up, and we just know no one cannot tell Delia, little Delia, she's gonna be a vet. Yep. I am there. I am working in the veterinarian's office. I'm helping out with research. I'm helping out even with fertility issues. Like, this is me. I moved to the area that has the school that I'm going to go to, and I'm going to undergrad in that area because that's the vet school that I'm going to. And then you get exposed and you're realizing, wow, I might not be able to do all the things that I think is going to happen. And then
I saw all these cool things, right? Yeah. There were so many cool things that they were doing in this big clinic.
But this is what exposure does, right?
Yeah.
Because now mentorship and exposure, it gives you an insight. Now, that might not be the only way. And, their opinions might not be the only opinions about veterinary medicine. But the exposure gave you an insight like, wow, maybe this is not what I want to do. And I can totally understand, because I knew that I was going to be a pharmacist until I was placed in the basement to file things in numerical order with paper charts. And I'm like, this just might not be for me. That's not what all pharmacists do, right? But I love it. So you had all your prereq to go to veterinary school last minute. So it's the checkbox: veterinarian school or medical school.
I just turned right and went to med school instead.
I love it. Alrighty. So now this is interesting, because now you go from, I want to take care of all the species, to just one. So, just the human race, right? Yeah. So you're here in medical school and you decide to do family medicine. What is it that brought you towards family medicine? Because you're unlike most people who went into, you were there thinking that I'm in this area because I'm going to be a vet. And now you're like, okay, I'm med school now. I have to figure out what I want to do in medical school. So what brought you to family medicine?
So I never thought about it until this second when you just said that. But veterinary medicine is all the things. And family medicine is like the medicine equivalent of all the things. I never thought about that before. I just couldn't decide, like, well, I like surgery and I like OB-GYN and I like peds and I like medicine. I just couldn't decide. And so that seemed like the container that had all the things. And so that's the direction I went.
I love it. I love it. And you're right. And, shout out to all of our family medicine doctors out there, because you're right. You guys are the originals who are taking care of everything, like we said, from the womb to the tomb, literally. Everything in between. You guys are trained to be there and to handle and to take care of that. So yes, we love and respect all our family medicine docs. Thank you for doing what you're doing, especially in a time when you're probably feeling undervalued. We care, and we totally respect all the work that you're putting in to helping our patients and the population. All righty, so now, Dr. Delia, you're there. You're doing it all. in family medicine.
Small town family medicine. I was in North Carolina at the time doing
Mm-hmm.
small town family medicine. And even inpatient medicine. So I came from Jefferson, right, where they had like a left thumb specialist and a right thumb specialist, you know,
Yes.
and I went to small town, and the ER would call me and say, this patient's unstable, you have to get here right away. And in my mind, I was like, well, shouldn't you stabilize them before you call the primary care doctor? They're like, no, that's not how we do it here. They're unstable, you better come stabilize them. I was like, oh my word. So I learned a lot. But anyway, yes, I was doing straight up family medicine. And here's what I found, though.
Mm-hmm.
This is how I went to integrative medicine next.
Mm-hmm.
In med school, you kind of get the impression you just take a great history, you do a great physical, you learn all the medicines and treatments, and then all your patients will get better. You'll do the right thing, they'll get better.
Yeah.
And then there's real life,
mm-hmm.
right? Where I had a zillion patients who were tired, they couldn't sleep, they have headaches, they have chest pain, but the cardiologist said it's not cardiac. And they just feel lousy. And so I'm like, all right, I'll check your thyroid, I'll check your blood count, we'll do cancer screening. It's all negative.
Yeah.
But they still feel terrible.
Mm-hmm.
And so in the beginning, I was like, well, they didn't tell me about that. What am I supposed to do about that? And so I started just using with people the things I used myself, like talking about, so how's your life going? And, you know, what do you eat? And do you move? And do you like your spouse? And, you know, is your job too stressful? And
mm-hmm.
starting to address people in that way, suddenly they started getting better. And I was just like, what is that? Like, what is that?
Yeah.
How come now? And then I had some patients who had fibromyalgia, and then I became sort of the local fibromyalgia doc, because they would tell their friends, like, oh, this doc, you'll get better. And they would come, and I would just do like human well-being things, basically, but they got better. And they hadn't gotten better with all the meds and things, because it was like a human thing. It was a well-being thing was the problem. And so then I was like, well, what is this? And how come I never learned about this? And I discovered there was this whole field of integrative medicine. And so that's what took me in that direction, from straight up family medicine into integrative medicine, where I was in academics for a while as the associate director of a center in a medical school for integrative medicine, did a lot of teaching around integrative medicine. So that for a while, I was like, okay, this is my bucket. This is where I sit in integrative medicine. And I loved it, and it's fantastic.
Mm-hmm.
And there was a little part of me that still felt like
there's more.
It's almost there, but it's not quite right.
The bucket was almost full. Well, remember, we started off by wanting to take care of multiple species, and now we're down to one, just the human race. And, you know, we went into the family medicine, where you had you're now using all the tools, right?
Yeah.
But then, even like we said in medical school, we are taught like in a linear fashion, but then there is more of a dynamic approach than that linear approach to helping people. So 100%. You're there, but you're 95% there.
I'm almost there, but
almost.
And two things really were nagging at me a little bit. One was some parts, not all for sure, but some parts of the integrative medicine community were a little bit anti-medicine, anti-pharmaceuticals. And I actually think pharmaceuticals are great. Yeah. They're not the only thing, but I don't want to cut them out either. So I always was a little bit more conservative than some of the people in my integrative medicine world. You know, they want to say, like, don't ever take any pain meds, don't take antidepressants, don't take any of that stuff. And I was like, well, not all the time. Sometimes maybe you should. Yeah. And then my younger daughter had an injury at one point, and we ended up having to figure out how to help her. She had about a 3-year recovery. And what really worked was everything. So the complementary modalities definitely were important, but medicines and procedures were important too. And I more got a feeling of, I want it all. I want it all together. Yes. And then the parts of medicine that I really liked the best were the deep conversations with people. And so I ended up being a hospice team medical director for a while, and I saw two things there that blew my mind, which were, one, the depth of connection that you get with patients when you enter into this world that they're facing is so much deeper and was so much more meaningful to me than, you know, writing a prescription for a UTI. It just filled me up in a different way.
Yes.
And I found the opposite of what I thought I learned in medical school, which is the people who seemed to be the most content with life were my hospice population.
Mm.
Right? Like they kind of teach you in med school, if you want to make people happy, you fix them.
You fix them, get them better, and then they'll be so happy.
Then they'll be so happy.
Yeah.
Right. So I had a lot of patients in family medicine who were better. There's nothing wrong with them, but they weren't happy. The people in hospice were not better, unfortunately, and they were not going to get better, but they grew this new perspective and made their life for whatever it was going to be the way they wanted it and focused on the things that were most important, and their happiness improved. And I felt like my mind was blown, and I loved that. And so then I became board certified in palliative medicine. I was like, oh, I really like palliative medicine because that palliative medicine is the mind, body, spirit care of patients and families with serious illness. But their toolbox was medicines and procedures, pretty much. And I'm like, but we have all these, look at these other tools that were in my integrated medicine box. You know, what about acupuncture? What about meditation? What about guided imagery? What about craniosacral therapy? What about massage? Those tools work here too. And so once I put the two buckets together, integrated medicine and palliative medicine, putting them together, now I feel like, okay, I'm finally satisfied.
We got the 100%. Like that circle is made. I love it. Wow, what an interesting perspective in putting all your tools that you've learned together and the journey to that part, right? The journey along the way. So you have the traditional medicine where we're taught to see and fix, right? And then you have integrative medicine, which is thought to do a little bit deeper. As you mentioned, there is a place for traditional medicine there where you had the personal experience in using that with your own family member. And then this world of palliative care comes about. And I do have to give a shout out to one of our palliative care and hospice docs who are here, Dr. Keshana Guidry, that's saying hello, hello, hello. Yes. Also at Morning Dove Medical. Yeah, she's there. She says that I could spend the rest of my career only conducting family meetings because,
yes, indeed.
Yes, as you mentioned, that once you step into that world, and you know, the world of palliative and hospice, the rest of those who aren't in that world look at it as, wow, that must be the most depressing time in any person's career. While those who are in the world, you have stepped in and, like, you know, just like Dr. Guidry, and you're like, no, the patients there are the happiest. They have found their purpose in life, and then they're living their true intentions and purpose right now. You know,
you're so right.
Putting all that together, Dr. Delia found her circle. The ring is complete.
Finally, I have to laugh because if I had friends who hadn't seen me in a couple years, you know, they'd be like, oh, you're doing family medicine. Okay, great. And then I'd pop back and, oh, now I'm doing integrated medicine. Oh, you're doing that. Oh, no, now I'm doing palliative medicine. Oh, I think people were like, can the woman not like pick a job? What is going on? But I feel like I was on a journey and now I got there. That this is it. And as you said, some people think that doing palliative medicine is depressing. It's, for me, it's the total opposite of depressing. It is, first of all, it's inspiring. It's so satisfying because helping people on that journey, because not everybody's intrinsically happy. You know, they get a tough diagnosis, they don't start out happy, but you can help people on that journey. And it's such an incredible reminder for me not to worry about stupid things. You know, like if I see someone who's dealing with a real serious thing, we've had a really intense communication and they're feeling better and I feel good about that. And then I'm like, oh, I gained 5 pounds. Whatever. Who cares? You know what I mean? Or that person didn't invite me to that thing, or my husband didn't clean up the whatever. Like, who cares? It just reminds you not to get upset about the stupid things. And when you take that stance in your life, you're just a happier person.
That's true. And, you know, that's a stance that once you step into the space, and even like one of our colleagues, Dr. Londonia, is saying, like, you know, with mindset and the mindfulness and recognizing living in the moment, you know, and I was reading a book today, and one of the quotes in it says, you know, we're always in a world where we're busy, right? And it says that I'm not busy, I'm full. I'm full
Mm,
of joy. I'm full of, you know, full of happiness, full, I have like full of intentions, full of things to do with my family. And I thought that that was just a beautiful perspective of looking at the world. And, you
I
know,
love
what
that.
are your ways of looking at things instead of saying busy? Busy is a negative perspective on time, but
Yeah,
fullness.
that's beautiful. I'm stealing that. So
Hey,
thank you.
you got it. I got it from someone else. But it's absolutely a beautiful perspective when we look at time and you look at someone who, for all intents, appears to be losing time, and therefore they look at what's most important in life.
Yep.
And the stories, as you and even like Dr. Guidry says, sitting down and talking to someone and really being able to get that perspective, that's gold.
Yeah. But here's the thing. We
Mm-hmm,
have a ton of magical thinking as human beings. Like
mm-hmm.
you might think about your loved one who has cancer and you're sure they're going off this planet before you. You don't know that.
Yeah,
Like we don't know. We literally
absolutely.
don't know.
Yeah.
So since we don't know, we might as well act today the way we would if we did know. Like if we knew we had 1 week left, what would that look like? We should.
Mm-hmm.
Now you can't like spend all your money and not save for
Yeah,
retirement. You
right.
can't totally do it, but but you
But
can say I'm not going to worry about the dumb things because I literally don't know how much time I have. But I know one thing for sure. I don't have forever. That I know for sure. Neither do you,
absolutely.
neither does anybody. Right?
Mm-hmm.
Like I have had patients say to me, this always strikes me. Well, how am I supposed to live now that I know I'm going to die when they have
Mm-hmm.
a diagnosis? And I think, didn't you know that before? Like,
Mm-hmm.
I'm going to die, right? We
Yeah,
all are. We don't know when. We hope it's a long time from now, but it may not be. We don't know. So the way
absolutely.
we should live is the way we should live, right? We should focus on the now the best we can,
Mm-hmm.
not ruminate on things that bummed us out from before, not
Yes.
worry about things that might happen in the future. Like we can plan for them if that's what we're doing now, but we shouldn't go, what if this and what if this and what if this and what if this?
Yes.
Because that messes up right now.
The right now. It
Right
messes up the
now.
present, which is the
Yeah.
present, right? It messes
Right.
up the I
Yeah.
lived my life as that person for
I know.
many years. And I think a lot of us do, especially a lot of us who are planners. And, you know, a lot of us who go into these careers that require a long sacrifice.
Yes.
We live in that, well, what if, what if, what if, what if, what if? The contingency plan. Well, I have a plan A, and if plan A doesn't work, plan B, C, you've taken so much time putting together the contingency plan that you're not living in the now. You don't get
Exactly.
a time to absorb, to look up from the computer or from that journal or from that paperwork with the A through Z contingency plan, to see the sunshine, to
Yeah.
see to listen to the laughter, to hear the water, you know.
Yeah.
And yes, the water, all my patients down here, I'm in Houston, Texas. I still have the Jersey accent. They're like, wait a minute, you said water? Yes, I did.
I like it. I'm from New York originally. I like it.
So yes, but to listen to the water and to just hear the peacefulness, you know, nature or whatever it is that brings that calmness and brings that essence of life to you. Take some
And
time to look up and to absorb and enjoy it.
and
Enjoy
I
it.
would add one
Mhm,
thing to that, which sometimes people don't think about, which is
mhm,
even if the moment that you're in right now is sad or
mhm.
hard, then be in that moment. That's okay.
Yes.
Because if you're crying about something that's sad, the thing that's not helpful is what if I never stop crying? Oh my God, what if I never stop crying? What if everyone leaves me because I'm crying? What if my friends are tired of talking to me? That's not helpful. But if right now you're just like, right now I'm sad. Right now I'm
Mhm,
sad. I'm going to go sit in my special chair. I'm going to have a cup of tea. I'm going to put my blanket on. It's not going to last forever. And right now I'm just going to be sad.
mhm.
That's okay too. and
Yes.
and sometimes people they push back at me on the being in the moment thing and say, well, I've got a plan for stuff. Like you can't just not take your car in. You got to plan things sometimes. Exactly. If in the moment you're planning, then you should plan. But don't think about, oh my God, this is thinking backwards now. I should have planned earlier. Why did I wait so long? Or, oh my God, now it's not going to work out. I'm planning wrong, or things not going to happen. That's in the future. That's worry. If you're planning right now, just plan. And I use it for medical students sometimes too. If you are open, your book is open, study. But here's what you shouldn't do. Don't say, oh my God, I should have started studying sooner. Everybody else has probably studied already for 2 months and I just studied now. What if it doesn't work? What if I fail? What if I don't get a residency? What if I'm homeless? Like all the time
and these are real thoughts, people.
They are. And all the time you did that, did you learn any piece of information about the heart? You did not. Right? Like if you're studying, study, be in the moment. That's your moment right now. Do that thing. If you're cooking, cook. If you're planning, plan. If you're going for a walk, be in the moment. It's that's it. Just that change makes a huge difference in well-being. And it works the same for people with or without serious illness. It's just a human thing.
Absolutely. That power of intention is powerful.
Yeah.
And it changes your life, it changes your perspective, and it changes a lot about you, your mood, even as you're talking and as you have expressed. If you are in a mood where you're unhappy and sad, be in that mood, acknowledge, allow it to happen, and you'll find yourself moving on from that.
And then let it pass. Exactly right. It gets stuck when you're like trying to stuff it in the basement and pretend it's not real. It comes back up again. If you just give it a moment.
At the most inopportune times.
Correct. Or as, a heart issue or high blood pressure or something, right? Or inflammation or trouble sleeping or depression or anxiety or all kinds of other things.
Yes. So we have the chat is blowing up with people saying hello. We have Dr. George Nam, that's Jeep, aka Jeep. Hello. Dr. Londonio. We have Vikash. Hello, Vikash. How are you? And we have Dr. Una that's saying hello to you. We have Dr. Kaishana Gidry, as we mentioned. Dr. Heather, hi. And we have some people on Facebook. Katie, thank you for joining us. And we're, being told that this is some great info and that absolutely self-assessment is so important and it's so powerful. We said to be in that moment, whether it's a moment of sadness. And I loved and I'm happy that I'm happy that you told us about being sad.
Yes.
Because it's true. Our intention is always to be happy, but we definitely recognize that happiness is not something that occurs 100% of the time. We go through different emotions, which it, evolves. And that's why we're dynamic beings.
And it's
It's important, to recognize it is okay to be sad, but what's the not okay is if you're just dwelling in sadness. We want you to acknowledge, absorb, live in that moment, but be able to release it and to move on.
For patients who have trouble they get stuck there, sometimes I would recommend setting a timer. And I would ask them, how long do you think you'll need? Like when you think about, or family members too, you think about your brother who might die and you get kind of stuck in that tough space. How long do you think you need? And they'll tell you, like, I need 15 minutes. Okay, great. So when that happens, you're going to set a timer for 15 minutes and you're going to feel whatever you need to feel. And you're going to cry if you need that, or scream if you need that, or hit the pillow, or draw, or hide under the covers, or watch Netflix, or whatever it is that you need to be in that space. But when that timer goes off, that's done. And then I ask them to say, what will you do once the timer goes off to help yourself get in a new space? Because sometimes you have to do something physically different, like
absolutely
push against the wall, go put water on your face, go for a walk around the block, go take a shower. It makes it easier to get out of that funk. Yeah. Yes. So I'll have them say how long they need, set a timer, and then what is going to be their transition thing that gets them to their new space. And then people really do it and it really works.
Absolutely.
And they learn they have some control over their feelings.
Yes.
Right.
And that's an important aspect. I love that you're saying you learn that you have control over your feelings, because a lot of times we feel as if this just happens to us. There's nothing I can do. I'm now stuck in this zone. But
Exactly.
when you allow yourself, as you mentioned, the ability to mourn, to be sad, but you do it in a way that you're controlling it. So you're not suppressing,
Yep.
which is the big difference that we're talking about.
Yep.
We're not suppressing the feeling, you're controlling it, and you're giving yourself a time to do it and an action to get out of it, which is
Exactly.
the important part, which I think intuitively we don't realize that that's something we can do. And therefore,
Exactly.
if you have not been taught that skill, you just feel as if like, well, now I'm now stuck in this feeling of sadness. What do I do next? So I love
Yep.
the fact that you said, oh no, be in there. How long do you think you need to be
Yeah.
in that state of
Yeah.
mind? Give yourself that time, but set a time limit. And when you've completed that time limit, what is it that you're going to do to get yourself out? So
Yep.
you've given yourself a door, an exit, a window, just a way to move from and transition from one emotional state to the next. And then
Exactly
the
right.
good thing about it is that you have these tools that you can always go back and use again when you're feeling that way.
Yeah. Yeah. And it works for any emotion, right? It works
Mhm.
for angry or sad or
Mm.
guilty or ashamed. It works for all the things.
Yes.
And the reason I want to teach physicians to do this is because look how simple, how quick that counseling is. Like you can do that counseling of a patient in 2 minutes. But when
Absolutely.
when physicians often think about like a patient being sad, they're like, oh, that's going to take me an hour. I don't have an hour. So I'm not even going to ask them if they're sad because what if they say yes, what the heck
Then
am I going
now
to
I'm
do?
stuck in this zone and I have to
Yeah,
do
and
it.
if they start crying, I'm going to like do something to make them stop doing that because I can't deal with their sad because it feels too
Mhm.
big and I don't have a tool. And so there's so many tools just like the one we just talked about. It's not a big deal. It's
Mhm.
really not hard. You just have to know it's a thing. It works. This is how you tell the person. And then they come back and they say, "Oh, you know what? I'm feeling much better."
Absolutely.
Because they learned this skill to manage their emotion and they didn't spend 3 hours stuck in sad feeling like they were going to feel this way forever and their whole life is fallen apart and they yelled at all their family members so everyone's ignoring them now and now they feel lonely. Like you
I
can
know,
go
and
down
now
a
guilt
funky,
comes into play, and so we move
right,
from sadness to guilt, and we're just moving.
totally. And instead they learn to tell their people, you know what, I need 15 minutes. I'm going to go do my thing. I'm going to set my timer. I'm going to go in here. When it's all done, I'm going to take a shower and then we can go have dinner. And it completely changes the experience. And you can do that whether you have cancer or not, whether you're on hospice or not, whether you have renal failure or not, doesn't matter. It's a human skill.
Wow. And as you mentioned, these are skills and tools that you have as a part of the Institute of Palliative Medicine that you are building.
Mhm.
So now let's think about and like let those who are listening, those who are watching, when did you decide that, you know what, I can actually teach these skills to my physician colleagues because they're just very, very small, powerful tools that can help them, as you mentioned, during times when you have a patient who might need that help, but you feel, I do not have the time to provide this level of care. But you, as physicians, we always want to help. And
We
when
do.
you feel that I don't have the time, that adds an additional layer of guilt on physicians themselves to
Yes.
not be able to provide that care. But you've come up with a solution for this, which is your Institute of Palliative Medicine. So tell us all about this. When did you decide to
Sure.
do it? And what are some of the additional things that you have in store to help us physicians?
Sure. So the way I got to this is because I started a practice, an integrative palliative medicine practice in a community hospital in Baltimore. And
Mhm.
so we had two parts to it, part outpatient and part inpatient. So I was the division chief of, we created a integrative palliative medicine program. I was the division chief of this program, inpatient and outpatient. And
Mhm.
we saw outpatient, mostly cancer patients. Inpatient, we got palliative consults from the hospital. So it could be anybody, but I taught the team integrative skills. We had a mind body specialist, we had an acupuncturist, we made a volunteer corps of people who did massage and Reiki and guided imagery, craniosacral therapy. And what I found was this: So in the beginning, when I started, the oncology team, the head didn't know like were any of his doctors going to send to this new weird thing. But they did. They sent a ton of patients. And here's why. It wasn't for people who wanted integrative medicine. That was not it. It was for people who had pain, for people who were anxious, for people who were fatigued or constipated or couldn't sleep or had perceived stress or had family conflict or were just overwhelmed by their cancer diagnosis, or who had to make medical decisions, or who had to decide, should I get a second opinion? Should I try this therapy or not? But I'm feeling really sick. So can I feel better enough with meds so that I can go perceive this, go after this therapy? So it was basically all the people with things that were not about curing the cancer or holding the cancer at bay. That's obviously the oncologist's view. It was things that were suffering, emotional suffering, physical suffering, spiritual suffering. So that's what palliative care does. That's the palliative care goal. But what we did was add these more tools, and it was magical. It was magical. And people got better. People coped better. They felt better. And what the oncologists, I think, saw was that sometimes it even made the treatment, the conventional oncology treatment, better, because if the patient was either refusing the treatment or felt so sick that they couldn't proceed, if we could get them calmer and feeling better, now they could proceed with their cancer treatment. We actually helped their potential survival, not because our stuff helped survival, but because we got them back into the medical system because we managed their symptoms.
Yes.
Right? And so it was just special. It was. And what I realized was I wanted more people to be doing this. This seemed to me like this is the thing. Like
it's like a unicorn that's sitting right there, but you can spread the rainbow magic throughout.
Correct. And so I realized if I keep doing this at any institution, I can see X amount of patients in my life. If I teach other physicians to be leaders in this world, my current big hairy goal is 1,000 physicians. Think of all the other patients who will be helped if there are other leaders in this space. Because what I kept hearing was, well, you're the only one who does this. Well, that shouldn't be, because this is clearly the right way. And it's not that hard to learn. And some people need to learn more of the medication management skills. Like, honestly, in the hospital, sometimes hospitalists would admit patients for uncontrolled cancer pain, and then because they were freaked out by their high doses, they would end up on lower doses of opiates in the hospital than they were at home. So there's
the purpose of going in the first place.
Right, it's crazy. So there's some education physicians can learn about how to comfortably manage opiates in the seriously ill population, which is different than for chronic pain. And also all of these other tools, like does acupuncture have evidence for? What does guided imagery have evidence for? How do you counsel a patient who says, I'm afraid to die? How do you deal with it so that you don't shut down all the patient's emotional or physical suffering? So I started this institute because I want to create 1,000 physician leaders who are as expert in this as I am.
And spread that magic throughout. Because if you have those leaders, and the leaders are spread throughout the world, not even just this country.
Correct.
You can imagine the power to help those who have these serious illnesses. You'll be able to help them be comfortable with some of the decisions. And, one of the things, so you have this beautiful podcast also for which you're discussed some of these same issues within the podcast, where having people be comfortable with the decisions that they're making, us as loved ones on one hand. One of the powerful podcast episodes, I think you might have just dropped this one, about 6 words, the words to say, or the phrases that we say to our loved ones. The fighter, don't give up. But when you have us as physicians out there who are equipped with the tool to help with these difficult scenarios, these difficult situations, then we can help the patients and their families when they have these difficult decisions to make, and be okay with their decisions. and not feel, like you said, like they're giving up because they said that my quality of life has changed. Because that's always a challenge for those of us who are not trained in palliative care, hospice medicine, as we mentioned, where we're trained to continue life. So, but when the patient is like, no, I am okay with stopping, we don't know what to do.
Exactly. And the system is sometimes set up that the patient then gets extruded from their doctors, which I think is terrible. Like, that one of the loveliest things about being close to an oncology practice is that they never had to stop seeing us. So we don't have any hard stop except when someone leaves the planet, right? Like
Right.
palliative care is not end of life care. It's serious illness care. So even a person with cancer who's trying to get cured, that's an appropriate palliative care patient. And so sometimes people get cured. Sometimes people have a very long life with an illness that's being kept at bay by their oncologist. And sometimes people die. And they don't ever have to say, okay, I can't see you anymore. We don't ever say things like, oh, there's nothing else we can do for you, which I hope no doctor ever says to any patient ever, ever, ever. And even this thing, this is in the podcast, I really don't like this, where sometimes physicians will say, well, do you want aggressive care or not? And I don't see it that way at all. It's always aggressive care. Who's going to sign up for their loved one and say, I do not want
you give me that
a
passive
good care.
half
Right.
and half
You just
care.
I want you to ignore them. Of course not. It's either aggressive disease-focused care, if we still have something that can help your disease, or if we don't, which happens, right? Because we're not magic. If we don't have something for your disease, then it's aggressive symptom-focused care. Either way, of course, we're going to give your loved one aggressive care. They matter.
Oh,
they totally
wow.
matter.
So you have to say that again, because I love the way that you phrased that. Because a lot of people, it's challenging coming up with a word. And you hear one thing, and if you think about us in medicine, right? We hear it if our senior attending, our chief, if our senior resident, if that's the way they speak, then when we go out, we're using those same words because that's kind of what we learned. But I love the way that you phrased that. So say that again. It's aggressive. There are two types of aggressive care.
Two types of aggressive care. It's aggressive disease-focused care if we have something that will help your disease, or if we don't, aggressive symptom-focused care. Why would anybody want to not have aggressive care for someone that they love? That's like, I'm not going to try. That's what that says. Do you want me to try to help you, or do you want me to not try to help you? Of course, no one's going to pick that one, right?
Absolutely. And and it's the words are just so powerful, because especially when the decision is made that, hey, I want the symptom focused at this point. And an additional phrase that I need you to say again for those who are in the back is about palliative care medicine, because Dr. Guidry and I, we talk about this frequently, in that the world of traditional medicine is still confused about the role of palliative care medicine. So explain again. And those who are not even in the medical field, it's even worse. So they hear the word palliative and they think that you just told me that you were giving up on me and you're rolling me out to pasture to leave me. So please explain.
So palliative care is symptom-focused care for people with serious illness. So let's think about that for a minute. Symptom-focused care, there's two parts to it: symptom-focused and serious illness. So if you have cancer, is that a serious illness? Yes. If you have cancer and you're trying to get cured and your doctor says, yeah, we hope we can cure you, maybe, and you're getting chemotherapy and now you're tired and you're nauseous. Do you have symptoms? Yes. Do you have a serious illness? Yes. So if you have cancer, you're trying to get cured, you're getting chemotherapy, and you have symptoms, you are appropriate for palliative care. We hope you get cured. Of course, we hope you get cured. And if you do, fantastic. And if you don't, we're still here to help you with your symptoms. And that's physical symptoms, emotional symptoms, and spiritual symptoms too, right? So for example, sometimes people on a palliative service can't sleep. So we'll help figure out, why can't you sleep? We're not just going to be like, oh, sleep, here's a sleep medicine. No, we're going to say, well, let's talk about it, figure this out. Why can't you sleep? Do you have pain that's uncontrolled? Well, let's fix your pain. Do you have reflux that happens whenever you lay down? Well, let's fix your reflux. Do you have anxiety and in your head you're going, oh my God, what about this? What about this? What about this? Let's fix your anxiety, right? Do you have some spiritual distress, like when you're alone at night, now you know you have this cancer, you're thinking about when you cheated on your spouse way back when and what's going to happen to you after death? Well, then let's send you to somebody that can help you talk about your spiritual concerns, right? So it's not about a sleep medicine. It's not like a lack of sleep medicine. It's looking at the whole person. It could be physical, emotional, spiritual, or multiple things causing that symptom. And we try to make them better.
Love it. I think with that, in addition to the other episode that we've had about hospice and palliative care, that I'm hoping that our colleagues and those who are not in the medical field can have a grasp as to what and how palliative care is so helpful as a part of the treatment for those who have serious illnesses. It's
yes,
not
spread the word. Please spread the word.
I am spread, and that's why I had you say it again. Thank you so much, because this is definitely one aspect of medicine that's still an enigma for those of us who are in the traditional base. Alrighty, so now we've talked about, like, you know, your institute for palliative medicine, where you're building leaders out there so that they can spread the word and spread the training that you've had, the arsenal that you have in the toolbox there for them. Now I'm going to bring it back to you.
Okay.
So what are you doing for self-care? Because I mean, this is a lot of work. So please tell me, how does Dr. Delia take care of Dr. Delia? What are you doing for self-care?
So the great thing about doing this work is I just pretty much follow my own advice, right? And if I learn a new thing, I share it with the patient. If the patient shares something with me, I try it out. So I have a whole bucket full of tools for myself, depending on the day or what I need or how I am. I do different things. So I definitely use positive reframing, meaning, you know, I don't like that thing, but at least something else. So I don't like that that my daughter's not feeling well, but at least it's not something serious. Or I don't like that the air conditioning went out, but at least it cooled off a little bit, whatever. So I constantly am trying to positive reframe, and not in a toxic positivity way, not in a like everything's great all the time. No, because sometimes it's not. So acknowledging what I don't like, but then not getting stuck there and trying to turn my attention to something that is better. I use mindfulness a lot. So if I find myself spinning off in the future, which I certainly do, I try to bring myself back to the present. I exercise. I do art. I make multimedia art for myself. And what I often find is I'm just making whatever feels right. And then it speaks to me and sort of solves a problem that I was having with myself that I couldn't solve. I hang out with my dog. I see friends. I read. I listen to music. So
are you dance? You like to dance?
I dance. I do.
I love it.
I definitely nurture connections because I think that's important for me.
Absolutely. I love that you just, like you said, I have a bucket of things that I do, and it depends on the day and what I need at that moment, which is all about, and that's what I am out here spouting about self-care, and that your self-care routine is a personalized routine. It's something like you said, what do you need at that moment? But just have a list in the arsenal of things to do, to pull from. You know, for me, I need to get a routine in the morning. Now, was I a routine person growing up? Absolutely not. I was free as a bird. But now I recognize, wow, this routine makes me feel even freer. I was actually confining myself by thinking that I didn't need a routine, right? And then I do other little things. Like, I like to sing. Can I sing? Absolutely not.
I wish I could sing.
I do every Friday night. I'm sitting downstairs singing. My poor husband has to sit and listen, but that's okay.
That's okay.
It brings me joy, and it has definitely brought a sense of relaxation. So I love that you have those lists. You know, you said that you do media art, and then pulling from that arts section solves a problem that you've had deep within. And it's not
Yeah.
until you have really gone into that other part of the brain, right? Where you're just not actively thinking, but you're just creating and creating. And then you've ended up solving a problem from that creative mode that you stem into. So I love, love, love. Alrighty. So now I know that this has been an absolute pleasure. But before I let you
Me
go,
too.
we have our other question that we need to know.
Okay.
Alrighty, so Dr. Delia, if you weren't a doctor, what would you be? Or a vet?
Huh. Or
Huh.
that, right.
Yes.
Okay. I have two answers to that.
Okay.
One is the regular person answer, which is probably I would have been a therapist, I think.
Oh.
But I also have this fantasy now, which could actually happen. And my husband lives in mortal fear of this fantasy because what I kind of want to do, like if $20 million rained down on me tomorrow, what I would do is I would start a dog hospice.
Oh.
I want to take care. It breaks my heart to think about the old sick dogs that people send to a shelter and that they spend their last time there. I want to get all the old and sick dogs and bring them to my house and have it set up to be a dog hospice and give treats and snuggle, and I'll change their diapers and carry them outside. And I just
Oh.
want the last part of their life to be good. And that's really what I want to do.
So the last part of their lives to be as meaningful as the care and love that they provided to their loved ones. What? You are my first dog hospice person. And I love it. That is such a beautiful thing. And you're right. Your husband's like, Lord.
He is like terrified that
Well,
it
the
might
lotto
actually
yesterday
happen.
was like, I think it was a couple $1 billion. So if I see Dr. Delia's dog hospice, I know what happened.
That's right.
Wow, that is so beautiful. I love it. I love it, love it, love it. Wow, that is wonderful. So, you know what, Dr. Delia, we have many people who are here, they listens, and like I said, the chat was really on fire with this beautiful message that you have that's there to help us physician. So I know people are like, wait, where can I find her? And when is her course starting? Can I be part of that course? Because I know that I can use those tools within my practice. And it's not going to add extra hours to my visit. It'll
Nope.
really actually impact my patient population with these tools, and it won't take that much time from what I'm currently doing. So where can they
Correct.
find you?
Okay, I would say there's two good places to find me. One is I would love if everyone would come listen to the podcast because we talk about a lot of these things there.
Mm-hmm.
So it's the Integrative Palliative Podcast, the Integrative Palliative Podcast, and it's on all the places that podcasts are. So come find me. There is a podcast website that's integrativepalliativepodcast.com. So if you can't find it other places, you could find it there.
Mm-hmm.
And then come to my website where you can sign up for courses and get connected with me so you'll know when all the next courses are available. And that is integrativepalliative.com.
Integrativepalliative.com. So it's very simple because she is the founder of the Institute for Integrative Palliative Medicine. You can find her wonderful podcast, Integrative Palliative Podcast. If you are looking for it online, anywhere where your podcast listening pleasure, Apple, Sprout, Spotify, then you'll be able to find it there. And also you can connect with her on Integrative Palliative Care. Is it integrativepalliative.com?
Integrativepalliative.com.
That's where the Institute for Integrative Palliative Medicine is on integrativepalliative.com. And for those, palliative has an extra I. It's palliative, not palliative.
Yes, Palliative.
Yeah, palliative.com. Thank you so much, Dr. Delia, for stopping by and for blessing us with these wonderful. You actually dropped a little bit of gems and tools for us. We have the tools of being in the moment, being present, acknowledging how long you need for that emotion, setting the timer, acknowledging what are your steps want to do to get out of that emotion. What is it that you're going to do afterwards? And then executing and getting it done. I love,
That's right.
love, 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 love it. Thank you so much, my fellow Jefferson alum.
Thank you so much for having me. This was really a lot of fun. I really appreciate
Oh,
it. And I love what you do. Thank you
oh,
so
thank you.
much.
Thank you so much. All right. So I know that all of you guys out there are like, whoa, this was fantastic. I know. She is awesome, Dr. Delia. And that's why I'm so happy that she is our 150th guest. I even put on my sparkly shirt for her to go with my background.
I love it.
If you would love, love, love to hear this episode again, you just jump onto our website, and that's yourcaringdocs.com, URCARINGDOCS.com. Select podcast, and you're going to see Dr. Delia's beautiful face. Just hit that listen here button, and then you'll be able to listen to this. Now, we love those 5 stars, and this was absolutely a 5-star episode, right? So leave us a quick review and let us know what you thought about this episode and also about the great things that Dr. Delia is doing. So you can always find her and the information in our listen notes, right? It is right there on the page. Now, if you are a doctor and you said, oh my goodness, yes, I have something awesome too, and I need to share it with the world, then you just send an email to Dr. Beckford at yourcaringdocs.com and we can book you. Keep in mind, we are booked 3 months in advance because there's just so many awesome docs out there. But I love, love, love to hear your stories. And I'm pretty sure others would love to hear the insights and all the wonderful things you are doing inside and outside of clinical medicine. So with that, we bid you all adieu. We love you for listening. Thank you so much, Dr. Delia, for coming on. And we will see you guys next time. Bye-bye.